Sure. So this is a phase 2 study, frontline for patients with older patients with newly diagnosed Philadelphia chromosome-negative B-cell ALL, using a combination of low-intensity chemotherapy with a hyper-CVD regimen, in combination with inotuzumab ozogamicin, which is an anti-CD22 antibody-drug conjugate, and then with or without the addition of the bispecific T-cell engager blinatumomab. It's a phase 2 study. The primary endpoint was to evaluate the response rate and really co-primary response rate and overall survival. We've enrolled 64 patients so far. So basically it's a combination of hyper-CVD chemotherapy alternating with low-dose methotrexate and cytarabine, and so this is a dose reduction of standard hyper-CVAD. The study has undergone several amendments, but the current iteration of the study, we give 4 cycles of this low-intensity chemotherapy in combination with fractionated inotuzumab ozogamicin. This is then followed by 4 cycles of blinatumomab, and then we do a maintenance regimen of standard POMP chemotherapy alternating with blinatumomab, and that's given for 18 months. So overall, we're decreasing the amount of chemotherapy given and also decreasing the overall duration of therapy, at least compared to standard hyper-CVAD, which is commonly given in this population. The primary endpoint was basically looking at the overall response rate. That was, we found that 98% of patients responded, so there was actually only 1 patient who didn't have a response. And of the responses seem to be relatively deep, with 95% of patients achieving MRD negativity. As far as long-term outcomes, so the 3 years complete remission duration was 76%, and the 3-year overall survival rate was 55%. And this compares very favorably to historical outcomes with standard hyper-CVAD in this population, where the 5 years long-term survival is about 20%. Well, I think this shows that there's always been a concern about whether or not we can decrease chemotherapy for these patients. We know that these older patients have a lot of toxicity when they're given intensive chemotherapy. However, when we decrease chemotherapy, typically we're concerned that we're not going to have durable responses. And I think that what we're seeing with this is that if we incorporate these monoclonal antibodies, very effective ones, that have been shown to be effective in the relapsed refractory setting, and move them into the frontline setting, we can see that we can improve outcomes with minimizing the toxicity of chemotherapy. Yeah, so I think the main toxicity, we still see myelosuppression, even though we are using lower doses of chemotherapy than with standard hyper-CVAD, for example. There are also specific toxicities to the monoclonal antibodies that we're incorporating. So veno-occlusive disease is a concern with incorporation of inotuzumab ozogamicin, and we saw that in 9% of patients. And also blinatumomab can have neurotoxicity, but this is very manageable. So we saw that in some patients, but again, those were not serious adverse events that led to any long-term negative outcomes. So one interesting thing that we saw is that even though this is for older patients, we did stratify the results according to whether patients were 60 to 69 years or 70 and older. And we see definitely a very significant benefit compared to our historical results in those patients that are 60 to 69. While we still see an improvement in the patients who are 70 and older, there is a very high rate of death and remission. I think because even though this chemotherapy is reduced, these patients who are 70 and older, they can still have significant toxicity even with these lower doses of chemo. So with the next plan is to do an amendment where we're actually going to decrease the chemotherapy further for these patients who are 70 and older, and then rely more on the inotuzumab and blinatumomab for then, hoping to strike a balance between having effective therapy but also decreasing the toxicity that comes with chemotherapy for these older patients.